Now, when you look, what does the liver do? It's a filter, okay? And it has some very close neighbors. So I'm going to talk to you about its neighbors, okay? You have Patty the pancreas, and you have George the gallbladder, okay? That live right in there in a triplex with Larry the liver, okay? So I'm telling you like that so you can remember what they do, okay? So, the liver. Lobes of the liver can be covered with scar tissue. The liver degenerates and lobes can be infiltrated with fat. They form cirrhosis, okay? Cirrhosis is generally caused by alcohol and drug use, okay? And it can be post-necrotic symptoms that can cause cirrhosis, biliary symptoms of cardiac. So you can have right upper quadrant pain. So like I said, when in doubt, take it out. Think about anatomically, where does it sit on the body, the liver, okay? And think about everything else that surrounds it. So you're gonna have some jaundice, yellow sclera, dark colored urine, clay colored stools, fruity or musty breath, and I'm just naming a few: ascites, weight loss, pruritus, and mental confusion. When you think about that encephalopathy that can occur, okay? Now, you also yesterday the labs that we're going to check for liver function: ALT, AST, and then we have LDH, okay, and GNT. We also have we can do an ERCP to detect common bowel duct obstruction. We treat it with diuretics, vitamin supplements like vitamin K and C and folic acid, and then lactulose to bind to the ammonia that produces to get it out of the body. Remember we said yesterday, lactulose and K-exolate, they're used like laxatives. But the lactulose binds to that ammonia to get it out of the body. So we want the patient to have a well-balanced diet, but we're going to limit protein because protein is what? Broken down and processed a lot in the liver. But if it's not functioning correctly, it cannot do its job correctly. So we're going to limit protein due to hepatic encephalopathy, high carbohydrate diet with adequate vitamins. And we're going to monitor her bleeding, okay? So we'll tell our patients to avoid razors and use electric razors at this time. If they do have to get a venipuncture for a blood draw or something, you gotta hold pressure for 5 minutes because their tendency to bleed is much higher. So, good skincare. We're gonna avoid perfumes, lotions, rubbing alcohol, mild soap. Diphenhydramine can be used for pruritus, okay? And that's also known as Benadryl. Pruritus is like the itching and the scaly skin. Monitor fluid and electrolytes. We're going to weigh the patient daily, but we're restricting their fluid. We're going to give them half of the daily amount, 1,500 mLs a day, okay? And we're measuring the abdominal girth. That ascites that can develop in the abdomen can be drained off, okay? So they might need a paracentesis or even a Levine shunt that can move some of that fluid off, okay? Let's answer this question. And remember, show me the number, the correct answer with your fingers. Gonna select all that apply. Correct answer, 3, 5, and 6. 3, 5, and 6. Because that's protein. Okay. Esophageal varices. Esophageal varices, it's a condition, it can kind of go hand in hand, it's one of the complications of cirrhosis. varices can rupture and cause hemorrhage, and the patient can go into shock. Now, when I talk about varices, I'm going to do lab test reports endoscopy to look down into the esophagus, the capsule endoscopy, where the patient swallows the capsule. That's a little video camera, and then of course they pass it out in the stool, but the doctor gets that video. They can see everything that's going on throughout the GI tract. Okay. Now, if the esophageal, and I'm gonna show you a picture of this one. If the esophageal varices rupture, the patient can go into shock because they're highly vascular. Okay. So yes, we have to prepare to give blood. You get the RN. You know, two nurses are gonna check everything, etc. Now, with it, you know, I guess but the esophageal varices, look like little polyps in the esophagus, okay? Little bitty polyps all over the esophagus. They're small, but if they rupture, like I said, they're highly vascular, okay? There is a method of the procedure they can do. It's with the Singh-Steichen Blakemore tube, okay? And when it's put down into the esophagus, it can cause pressure and cauterize all those wounds. Okay? Hepatitis. We have A, B, C, D, E, and G. Which ones do we have vaccines for? B and I heard somebody say A. Yes, A and B. We have vaccines for A and B. Okay. These are the risk groups listed here on the screen. Okay. Chronic conditions, healthcare workers that are employed in high-risk areas, homosexual activity, okay, IV drug users, and that with IV drug users is transmitted by contaminated liquids. Okay. Contaminated liquids. Also tattoo and body piercing with contaminated liquids. Symptoms: fatigue, jaundice, anorexia, dark hair, joint pain, and muscle aches. And then of course we're testing those liver enzymes. We're testing bilirubin, leukemia, hypoglycemia, and the antigens. So patient will be very fatigued. So you're going to educate them on having frequent rest periods, good nutrition. We talked about if encephalopathy is an issue, they're going to have low protein. Okay? And remember, 1,500 mLs of fluids. We're going to cut that normal volume in half. Now, Patty the pancreas. We're going to talk a little bit about her because she is that neighbor that you just wish would move. Okay? Patty, with pancreatitis, Patty has those wild parties, okay? And she just starts auto-digesting herself. That's pancreatitis, okay? So think about where she lives in between the liver and the gallbladder, and she's auto-digesting herself, okay? So, just think that she turned into a little piranha and she's just eating herself all up in there between the liver and the gallbladder, okay? So, I'm making it very graphic because it is. When patients come in, guess what? Anatomical position. They're usually doubled over in severe, excruciating pain, okay? It can cause infection leading to sepsis, okay? If it causes sepsis, guess what? Patient needs to bleed out, okay? All right? They're going to septic shock him, hypovolemic shock, all right? So, if a patient presents to you with that, what are we doing? How are we treating? Definitely with pain medication.
Anti-inflammatories, fluid.
Anti-inflammatory fluids. Okay? That pain is located in the left upper quadrant. It can radiate to the back. It's a sudden onset. It's aggravated by an E. You want to remember that. That's hallmark signs. It's aggravated by an E, and it's not relieved by vomiting. Okay? Pancreatitis. Accompanied with flushing, cyanosis, and dyspnea. Now, other acute symptoms of pancreatitis, because of the location and what and how bad it's acting up in there, you get the Turner sign. On the left side, the whole flank is bruising, okay? Because what? We got pus, inflammation, could be lots of bleeding in there, okay? And then you get the Cullen sign, that seat that's around the umbilicus. Okay? So those are hallmark signs for pancreatitis. Low-grade fever, bowel sounds may be absent because of where it sits. It could possibly cause an ileus. Hypotension, tachycardia. What are all those signs of? Shock. Okay. Hypotension, tachycardia. The heart only knows to beat faster. Hypovolemia because of the massive fluid shift into the retroperitoneal space. Okay. Because the fluid has to go somewhere. Okay. It has to move somewhere. So again, remember anatomical location, what it does, what it sits around. You're going to see some of those same signs and symptoms. Okay? This is a picture of the neighbors. Okay? You can kind of see the gallbladder kind of peeking out because it's afraid of what Patty Pancreas is going to do to it. Okay? Because they did call the cops on her because she was disturbing the peace at 3 a.m. Okay? So, when patients have this kind of pain, unless they've had acute bouts of pancreatitis before, they're running to the emergency room because the pain is excruciating. Okay? Now, chronic symptoms, stenoria, we talked about stenoria yesterday, diarrhea, jaundice, ascites because of where it sits, and weight loss. Okay? So, an acute management, NPO. Okay? NPO, we're going to do an NG tube to suction to decompress the gut. Morphine for pain. They're going to be sitting up and leaning over because that helps reduce the pain. Monitor blood sugar and teach fluids and foods to avoid. They will need pancreatic enzymes. Guess what? Because Patty just auto-digested herself and our pancreas can't do its job. So, this is something you need to remember. Pancreatic enzymes can only be given with powder forms, with fruit juice, applesauce. You do not mix pancreatic enzymes with protein. Let's answer this question. So this is a negative question. You're looking for something that's incorrect? Yes. Yep. The right answer is 1. Okay? You do not mix pancreatic enzymes with protein. When we look at cholecystitis and cholelithiasis, okay, we're talking about the gallbladder. The gallbladder really tries to mind its own business, okay? But cholecystitis is acute inflammation of the gallbladder, okay? Cholelithiasis is the formation or presence of gallstones. So, symptoms, yes, pain, fever, elevated WBC, abdominal tenderness, and jaundice, because it's located, okay? Now, analgesics for pain, they're going to be NPO in the acute phase, NG tube to suction to decompress the gut, IV antibiotics, low-fat diet, and they're going to avoid fried, spicy, and fatty foods. Cholelithiasis is a non-surgical removal, so there's ERCP, which stands for endoscopic retrograde cholangiopancreatography, okay? So, and there's also lithotripsy, where they try to break up the stomach, okay, with laser. There's a surgical approach. It can be cholecystectomy, laparoscopic, or open, okay, to remove the gallbladder or just remove the stones. Let's answer this question.
answer is 3. We talked about that yesterday. You just wanna assess and document because it's expected with that. UTI. You wanna get a clean catch specimen, okay? So you wanna instruct the patient on how to do a clean catch, administer antibiotics as prescribed. See, after we've gotten that UA urine culture, we're gonna give them antibiotics as prescribed, instruct them not to skip doses and to complete the whole course of medication. We want them to drink their normal daily supply of fluids, 3,000 mLs. Encourage voiding every 2 to 3 hours, and avoid tight clothing and avoid bubble baths. Urinary tract obstruction, it can be caused by calculi or stones, okay? Usually if they have flank pain, that kind of tells you where the stone is located. If it's in the flank, the stone is usually in the upper urethra. Okay? If the pain is radiating to the abdomen, it's usually in the urethra or the bladder. So again, potted or given for pain, and strain the urine. You want to catch that stone, okay? Encourage high fluid intake, so if I do a little more than our normal daily, at least 3 to 4 liters, okay? Because you want to flush that stone out. Strict INO and surgical management may be required. So, benign prostatic hyperplasia. Think about the little orange, the little cuties, okay? And think about a straw up the middle of the cutie. The straw is the urethra, the cutie is the prostate, okay? Now, having said that, if it's hyperplasia, either an overgrowth tissue, okay, it grows inward, causing that the urethra to narrow, okay? So it's squeezing that straw because it's growing inward, okay? So think about your patient. They're gonna present maybe with a distended bladder, pain, okay? They're not able to fully empty the bladder. When they do urinate, because it's squeezing urethra, it's painful, okay? They can have bloody urine, some cloudy urine, because that urine that sits in the bladder stays stagnant. It's holding on to that bacteria that the body's trying to flush out, okay? So, benign prostatic hyperplasia, again, surgical options. Most common treatment is the TURP, transurethral resection of the prostate, okay? So what happens is, they go in, think about the inside of the orange that we call, okay? They can laser that part of it out, okay? Then what's gonna happen? The urethra pressure's gonna be gone, the urethra will open up, okay? But you're gonna have to instruct your male patients on how to do Kegel exercises, so they won't drool, okay? Until they get strong, all right? So, if the prostate's too large, the doctors will have to do a suprapubic approach where they go into the pubic area and make an incision to do the surgery, okay? Now, pre-op teaching, you're gonna teach about pain management and the oversized balloon catheter that they will come out of surgery with. Now, that whole setup with that catheter is called CBI, continuous bladder irrigation, okay? It's gonna have a bag of fluids that is gonna be running through one tube, and then you have the Foley catheter in the Foley bag that's gonna be lower than the patient's thoracic cavity and bladder, okay? So, that fluid is to keep flushing the system out so that the patient won't have clots, okay? It's gonna be light pink, then of course pinkish red to light pink, and it's gonna clear within 24 hours, okay? If the patient, when they go home, start having any bleeding and clots, they need to call their urologist, call the doctor, okay? Medicines that would be given for pain, we do give medicine for bladder spasms, like belladonna, okay? Oxybutylene, just some of these, and then dicyclomine, hydrochloride, some of these are given for bladder spasms, okay? Now, reinforced teaching that they need to drink that water, 3,000 to 4,000 mLs a day, 12 to 14 glasses of water per day. Avoid straining, avoid heavy lifting, and avoid intercourse in sports for 3 to 4 weeks. And again, report any large amount of blood or clots. Let's answer this question. Correct answers are 1, 2, and 5. 1, 2, and 5. With acute kidney injury, remember we said acute, we can find the insult and reverse it. So, it's a reversible syndrome if symptoms are caught early. So, remember this, I've been telling y'all like little by little, every day, several times a day, since yesterday. Kidneys need 25% volume, okay? 25% perfusion in order to function, okay? You wanna remember that, because I'm gonna tell you something else in a minute. Now, kidneys excrete 1 to 2 liters of urine per 24 hours for adults. 3 types of kidney injuries: pre-renal, intrarenal, and post-renal. This is a picture of what that looks like. If it's pre-renal and something happens with the cardiac system and the heart is not pumping blood, the kidney is not getting the perfusion it needs, okay? Kidney injury can occur. As soon as we find the insult and fix it, we can correct it. So that's a pre-renal situation that can happen, okay? Decreased cardiac output causes decreased renal perfusion. Now, an intrarenal problem that can cause acute kidney injury, it happens in the kidneys. It could be nephrotoxins, we talked about some of those meds yesterday, infection, kidney infection, renal injury, or vascular lesions. That's intrarenal acute kidney injury. Post-renal failure, acute kidney injury, that's gonna happen in the ureters and the bladder, okay? It could be from obstruction from stones, benign prostatic hyperplasia that we just talked about, because that stagnant bladder can sit in there and cause infection, tumors, or strictures. Okay? So again, we're monitoring our labs, okay? We're looking at how much urine output the patient has. We know that the BU and the creatinine are gonna be elevated because kidney function is altered, okay? But we're gonna monitor those labs. This is what it looks like in the olivuric phase. Decreased sodium and decreased pH. Metabolic acidosis is what you can see. Now, laboratory testing during the diuretic phase, increased urine output, okay? So, therefore, decreased fluid volume, because it's gonna be a lot of urine out. Decreased potassium, decreased sodium, because it's going with the fluid. Urine-specific gravity is decreased, and urine sodium is again decreased. Now, during the olivuric phase, we're only going to give enough fluids to replace what was lost. Possibly 400 to 500 mLs in a 24-hour period. We're doing very strict INOs. We're monitoring lab values closely. And we're doing those strict INOs and decreasing that fluid, only giving what's lost because the kidneys aren't functioning that well, so we don't want to give them a whole lot to have to try to filter. We're trying to not put a lot of work on them, okay? Now, you want to monitor their weight gain, because you're looking for any weight gain overnight. Let's answer this question. Answer is 4, just the gelatin level, okay? Because that potassium level, okay? Because we don't want to give them anything that could contain potassium. CKD, chronic kidney disease, end-stage kidney disease, okay? It's progressive and irreversible. Damage has been caused to the nephrons and glomeruli. Causes can be diabetic nephropathy, hypertensive nephrocirrhosis, or taste, and mouth itching, increased creatinine, increased pain, increased POC. And at the end stage is inuria. Remember yesterday I told you, inuria does not mean no urine. It means less than 100 mLs out in a 24-hour period. Okay? It could be none, but it's less than 100 out in a 24-hour period. So we're monitoring electrolytes, weighing the patient daily, strict iron, and then they get their renal diet. Everything's low in a renal diet. Low protein, low sodium, low potassium, and low phosphorus. Medications that we use, we're treating complications that could occur. So, these are the medicines: aluminum hydroxide to bind the phosphates, Epitin to treat anemia, antihypertensive therapy, calcium supplements, and vitamin D, antihyperlipidemics, statins to lower LDL, and fibrates to lower triglycerides. So remember, a lot of the meds that patients take, they're either metabolized in the liver or the kidneys. So if there is a chronic kidney disease, we need to think about the meds that the patient's on that are metabolized through the kidney, and talk to the doctor about changing some of those meds and changing the dosages. Now, there are two types of dialysis. There's renal dialysis and peritoneal, okay? With renal dialysis, it's called hemodialysis. The patient will usually have an AV shunt or AV fistula, okay? That they're getting their dialysis treatment through. They should have no vena punctures, no IVs, no blood pressure in the arm where the AV shunt resides, okay? Now, you're going to hold any medication that would affect the hemodynamic stability of the patient prior to them having dialysis of that day. Okay? It's just gonna get washed out. Now, peritoneal dialysis, the main thing you need to remember, what goes in, what's coming out. Okay? So the indwell time and the outflow time. Okay? They have a catheter in their abdominal area. That's where the fluid, dialysate fluid goes in, and then there's a bag that'll be on the floor lower than the area of the thoracic cavity and the abdomen, and the fluid that goes in must come out. And you're gonna monitor those INOs closely. Now, when you see this picture with kidney transplant, yes, they leave the affected kidneys in, okay? Let me tell you why. Look at the renal artery, okay? And then you have the renal vein. If you did all that work and surgery on renal artery, renal vein twice, then, two times each, then you gotta go back another time because you gotta re-anastomose the transplanted kidney to the renal artery, renal vein. Too risky, okay? Too many chances of bleeding out because you're messing with the renal artery and the renal vein. With the transplant, the reason they leave everything there is because you only have to focus on that transplanted kidney, okay, in that area. And you're assessing for infection, any signs of hemorrhage, okay? You want to see what? Urine. You want to see urine production. You know that new kidney is broken, okay? So you're assessing all the drains and output from all the tubes. Strict INO, you're giving narcotics and analgesics as needed, you're monitoring for shock, and you're monitoring the surgical site for bleeding, okay? And of course, you're gonna teach them how to splint their heart with the pillow at their incision. Let's answer this question. Remember, I told you something specific about dialysis, okay? They they will correct any elevated electrolyte imbalance with the dialysis. Okay? So potassium is the correct answer. Because the elevated serum potassium, it's elevated. The other ones are increased. It didn't say they were elevated, okay? And the other one was reduction, but it didn't say it was too low. Okay? So, with this question, select 5 assessment findings that require immediate follow-up by the PN. Okay? So I want you to read this case scenario and then select the correct answer choices. Okay? And then I'll show you the answers just the same. Now your correct answers here. 3, 4, 5, 6, and 7. We're gonna go ahead and get into chapter 7. I'm gonna stop at 10 and give you all of them. You can do this. I know a lot of stuff is coming back to the forefront. So with the regulatory, reproductive, and urinary system, we talk about obesity, metabolic syndrome, prediabetes, and diabetes. So, obesity occurs when caloric intake exceeds the body's metabolic rate. We assess by using BMI. That's the body mass index. You have normal weight, overweight, obese, and morbid obese. Our assessment as the nurse, as we're assessing the patient, we're looking for risk factors, okay? Of course, diet, exercise, sedentary lifestyle, things like that, genetic predisposition, cardiovascular disease, hypertension, sleep apnea, and type 2 diabetes. The metabolic syndrome is a collection of these risk factors, okay, that increases an individual's chance of developing cardiovascular disease and diabetes. If they meet 3 or more of the categories listed below, okay, then they qualify for metabolic syndrome, okay? You look at the waist circumference, the
chemotherapy. The key thing is if they're obese or overweight, block the patient to lose weight, okay? You gotta put them on a different path. Even behavior modification, different inflammation. So there's all kinds of different medications. Orlistat is just one that blocks the fat, and it breaks it down into the GI tract in the patients, and excrete the fat in their feces. There's bariatric surgeries. You have the gastric sleeve, the gastric banding, gastric bypass. And again, you have to meet certain criteria to qualify for those surgeries, okay? You have to have nutritional assessments, psychological assessments, okay, physical assessments, and you have to meet criteria in order to qualify for, like I said, those surgical processes. Now, you want to know the difference between pre-diabetes and diabetes. Pre-diabetes just means there's an increased risk for the patient to develop diabetes. The fasting blood glucose for pre is 100 to 125. The 2-hour oral glucose tolerance test values for pre-diabetes, 130 to 199, and the hemoglobin A1C level for pre-diabetes is 5.7 to 6.4. When we look at the types of diabetes, we have type 1, type 2, and then there's some other types of diabetes, okay? Type 1 is rapid onset, occurs at any age. The symptoms, you have polyuria, polydipsia, and weight loss, okay? Type 2 occurs between the ages greater than 45 years of age and a BMI greater than 25. A first-degree relative may have diabetes, sedentary lifestyle, history of gestational diabetes, or a baby that's greater than 9 pounds. Cardiovascular comorbidity also goes hand in hand with type 2. Now, when I say there are other types of diabetes, you know them well, but you really don't kind of compare them to type 1 and type 2. But it's like gestational diabetes, okay? Steroid-induced, because we know steroids make blood glucose go up. And then there's hospital-related hyperglycemia. That's only when patients are on like dextrose, D5W, lactated ringers, and things of that nature. Of course, when you check their blood glucose, it's gonna be high, okay? And there's also cystic fibrosis related and transplant related. Remember I told you yesterday, glycosylated hemoglobin and hemoglobin A1C mean the same thing, okay? Now, you all told me that a hemoglobin A1C checks the blood glucose level over 3 months, 90 days, okay? To see how well the patient is managing their blood glucose. For diabetes, hemoglobin A1C greater than 6.5 is considered diabetes. A fasting blood glucose greater than 126 is considered diabetes. A 2-hour oral glucose tolerance test greater than 200 is considered diabetes. And a random blood glucose level greater than 200 is considered diabetes. Take a look at this picture. Let it soak into your memory. These are all the complications that are related to diabetes. And I know yesterday y'all heard me when I kept saying, and another risk factor is diabetes, another risk factor is diabetes. Diabetes can actually affect a patient from head to toe, okay? And I just got to name a few: cataracts, stroke, hypertension, coronary artery disease, gangrene of the foot, okay? Diabetic neuropathy, peripheral neuropathy, neurogenic bladder, okay? Just to name a few. So, it's key that you teach a patient how to keep tight glycemic control and manage their blood glucose. The skin can break out, okay? Especially with neuropathy, they might not even know that they have a sore because that decreased sensation in the lower extremities in the feet, okay? Eyes, I just talked about some of these: cataracts, edema, peripherals, cool skin, thick nails. What you see here on the picture, that's called linea nigra. It's just a darkened area that goes around the neck
You're gonna teach your patients about their medications, you're gonna teach them about their insulin practice, checking their blood sugar prior to taking their insulin, okay? You'll advise and educate them on whatever regimen the doctor has ordered. But you wanna refrigerate unopened insulin, okay? And eat heart-healthy diets, with consistent, carb intake, especially if they're taking insulin. But they're gonna manage the types of carbs they're eating, okay? Proteins, saturated fats, and then you want them to integrate meals and snacks with insulin therapy, especially have a snack before exercise. Teach them how to monitor for signs of hypo and hyperglycemia. I know you all probably have heard the terms hot and dry, my sugar's high. That's how the easy way to teach your patients about hyperglycemia, and then cold and clammy. Give me some candy. A good way to teach them about the signs and symptoms of low blood sugar. Okay? So again, have them manage with foot care. Okay, see a diabetic foot doctor if they need to. Manage their sick days. They should continue their insulin, check their blood sugar more frequently, and watch for signs and symptoms of hyperglycemia when they are sick. Let's answer this question. Correct answer is 3. Okay? That hemoglobin A1C, it goes from 9 to 6. Okay? So they're working on it. They're doing a good job. Let's answer this question. Correct answers: 2, cold and clammy skin, and then 5, unsteady gait and slurs. These are some of the other medications that we give patients for diabetes. Okay, sulfonylureas, biguanides, and I'm just naming a few of them. Dipeptidyl peptidase 4 inhibitors. They slow the inactivation of the incretin hormones. And then you also have the amylin, the analog, a synthetic analog of human amylin. You want to know insulin, okay? You want to know that there's rapid acting, okay? You want to know that there's intermediate and that there's long acting insulin. When we talk about these insulins, you also want to be sure that your patient understands if they're taking insulin, they need to eat, okay? So, you have, and I'm Lispro, okay? Lispro and glutamine, they both are given within 15 hours of the meal, and they have a 15-minute onset. These are some rapid-acting insulins, okay? They peak within 1 hour of their duration. Glutamine lasts 2 to 3 hours in the body system, okay? Humalog or Lispro lasts 4 hours in the body system. Now, when we start getting down to the Aspart or the regular insulin, okay, onset is 30 minutes, okay? Peak for Aspart is 1 to 3 hours, okay? It peaks and it only stays in the system for about 3 to 5 hours. Regular insulin, its peak is within 2 to 4 hours and it stays in the body system for 5 to 7 hours. Now, when we get to Humulin N, and Humulin N cannot be mixed with any type of long acting. The regular insulins cannot be mixed with long acting, okay? Now, N can be mixed with the rapid actings, okay? So you want to know that information. Now, the onset of Humulin N, again, that's an intermediate. Onset is from 1 to 2 hours. It peaks within 4 to 10 hours, and it lasts in the body system from 10 to 16 hours.
long-acting insulins like glargine and detamir, okay? Also known as Lantus and Levemir, okay? These medications are long-acting, they stay in the patient's system for 24 hours. But there's a difference between the two. You wanna know that difference? With glargine, it's given once a day in the morning, onset is 1 to 5 hours, it has a plateau. And it's gotta be the same throughout after that 5-hour onset. And it stays in the system 24 hours. But with detamir, onset is 3 to 4 hours. Okay, it takes a while for it to kick in, but it doesn't have a peak. It's sort of like a basal insulin, okay? It's giving that patient that same little dose throughout the 24-hour period, okay? And that's what detamir does. So again, and this part is in your book, you can just take a look at that. It's just talking about how if you mix Humulin in with the different insulins, et cetera, what the onset and the peak times will be. Okay. Now, when we start talking about the thyroid gland feedback loop, you have TRH, you have anti-pituitary, T3, T4, TSH, and the thyroid gland, okay? And it's not up here, so don't forget about that parathyroid and what it does. We talked about that yesterday, okay? With hyperthyroidism, listen to the terminology, look at the word hyper. Your lab values and things you're looking at are gonna be elevated, okay? Exophthalmos, weight loss because metabolism's increased, elevated T3, elevated T4, diarrhea, tachycardia, elevated heart rate, and you can hear brewing over the thyroid, okay? So they're gonna need a diet since metabolism and everything's high in protein and high calorie, okay? But low caffeine, because we don't wanna increase that metabolism any more than it already is, and low fiber, because they already have diarrhea. The treatment can trigger hypothyroidism. Yes, because we're either gonna ablate that thyroid out, they might have a thyroidectomy, or we do the iodine treatment that can burn it out, okay? So yes, the treatment will trigger hypothyroidism. And again, there's PTU, that's the blocks the synthesis of T3 and T4. That's the type of therapy. And of course, like I said, that iodine therapy destroys the thyroid cells. Again, looking at hyperthyroidism, if we do the surgery, do thyroidectomy, you want to monitor your patient for bleeding, okay? So you're going to trek around the neck and you're checking for excessive swallowing because we're monitoring for bleeding, okay? You're monitoring for signs of laryngeal edema, but it might also have that high-pitched stridor because there's edema in the larynx, okay? Now, you want to have a trach set at the bedside because if they get that laryngeal edema and it starts swelling up and closing off their esophagus, they're going to need an emergency trach. So that is just something that will be automatically placed at the bedside with this type of surgery. And we're going to place calcium gluconate or calcium glucosate at the bedside. Why is that important with the thyroidectomy? The parathyroid sits right there beside the thyroid. And sometimes during surgery, that parathyroid can be inadvertently nicked or even accidentally removed. Okay? So, you got to be ready to take care of the calcium levels. Okay? So, calcium gluconate or calcium glucosate should be at the bedside along with that tracheotomy. Now, when we're looking at hypothyroidism, listen to your wording and terminology. Hypo, low, decrease, okay? So here, you're gonna have low T3 and low T4. Cold intolerance, weight gain, because metabolism slow, constipation, bradycardia, slow heart rate, and fatigue. So be alert for mixed edema coma and an acute exacerbation of hypothyroidism. So you're maintaining that airway, teaching medication regimen, monitoring for side effects of medicine. And the medications, oh, and of course constipation, because everything's slowed down. With hyper, they had diarrhea, hypo is gonna be constipation. Okay. Now, if the patient's taking levothyroxine, they wanna take it prior to taking their food, monitor the heart rate, and hold for a pulse greater than 100. Other meds, liothyronine can be given. It increases the metabolic heart rate, because remember, we're trying to get things back to normal, because with hypothyroidism, everything is slow. We're checking the hormones regularly. Avoid food containing iodine, because if the thyroid levels are already low, then iodine is gonna lower them further. Okay? What kind of foods contain iodine? Shellfish. Okay. So again, let's answer this question.
Correct answer is 3. Maintain a warm room temperature. Let's answer this next question. Stressing this so you can remember, removal of the parathyroid during the thyroidectomy can lead to a decrease in serum calcium. And so side effects of because we talked about hypocalcemia yesterday. Some of those side effects, harsh vibratory sounds on expiration, tingling of the lips, hands, toes, and a positive Chavostick sign are symptoms of low calcium. Okay? And the other symptoms do not indicate the removal of the parathyroid gland. Remember the picture of the lady and tapping the jaw, the twitch? Okay. Addison's disease. Some causes: sudden withdrawal from corticosteroids, hypofunction of the adrenal cortex, or lack of pituitary ACTH. When patients are on steroids or corticosteroids, be stressed to them. Do not stop them abruptly. Follow the prescription. Take them as prescribed by your doctor. Okay. Symptoms for Addison's disease: weight loss, nausea, vomiting, anorexia, hypovolemia, hypoglycemia, and hyponatremia. Okay. The only thing that's elevated is the potassium, hyperkalemia. Now, postural hypertension, loss of body hair, and hyperpigmentation are hallmark signs, of course, of Addison's disease. Okay, so as the nurse, you're weighing them, checking the vital signs, monitoring electrolytes and glucose. Their diet, high in sodium, because remember sodium is low, low in potassium, because remember potassium is high with acids, and high carb. They're gonna have that 3 liters of fluid a day. We're looking for symptoms of overdose or underdose. Okay, if the patient has Addison's disease, they need to wear a medical alert bracelet. Okay, because all these symptoms kind of can look like any other disease process. Okay, especially with the hypoglycemia, they might assume what they're diabetic. Okay, so instruct the client to carry an emergency kit of 100 milligrams of IM corticosteroid. Let's answer this question.
Why is it so cold in here? Shelly, see if you can turn that AC up some. See if you can turn that AC up some, please. Up. Yeah, it's cold as hell in here. What is it on? Yeah. I started with my little heater.